Hello, everyone. Welcome to today's RettSyndrome.org RettEd webcast, A Good Night's Sleep for All, with RettSyndrome.org's good friend, Dr. Daniel Glaze, neurology professor at Baylor College of Medicine and the medical director of both the Bluebird Circle Rett Center and the Children's Sleep Center at Texas Children's Hospital. This is Paige Nuez, Director of Family Empowerment at RettSyndrome.org, and I will be your moderator today. Our board of directors and all of us at RettSyndrome.org want to personally thank you for your support and engagement in improving the quality of life for all of our children and families. Rett syndrome is a rare disorder, and as such, continuous awareness, empowerment, and research is everything. I say that as both a parent to a beautiful 16-year-old teenager with Rett syndrome and as your representative at RettSyndrome.org. Education, connectivity, and advocacy are the necessary tie that binds us together into our rare but mighty Rett community. While research towards granting the ultimate wish of a leads us at RettSyndrome.org to focus a lot of time and energy in the research arena, we remain steadfast in our concern with the health and well-being of our children today. And in that vein, we're so pleased to bring you today's presentation. With Rett syndrome being a childhood onset disorder with a prognosis of living well into adulthood, all of us have a very deep and long relationship to our loved ones with Rett syndrome, and a good night's sleep is paramount to this foundation, both for your child's health and well-being, as well as for yours. Today, Dr. Glaze is going to educate us about the common types of sleep issues that can occur in Rett syndrome and some of his best strategies for addressing them. Before we begin, I'd like to share some brief tech points on how GoToWebinar operates if this is your first time joining us. To begin, the audio feed is open to our presenters only, so you don't have to worry about your background noise interfering with the presentation. If you look to the upper right corner of your screen, you will see a control panel window. We invite you to type your questions or comments in the question field throughout the presentation, and we will answer these at the end of the slide presentation, as well as any questions that you may have pre-submitted at the time of your registration. If we don't get to your question today, we will work with Dr. Glaze to get all writing questions answered and post a QA document to our RettEd webpage once completed. If the control panel window is distracting to you, you can minimize or move the window, then you can expand it anytime you wish to submit a question. Next point, this is really important, everybody. The session is being recorded, and we will post a link of the recording along with the QA document, if needed, to the RettEd webpage so you can listen again or share this valuable presentation with others. If you're having trouble hearing, please check and turn up the volume on your phone or device. So with this, I'd like to now introduce Dr. Glaze and turn the slide presentation over to Dr. Glaze and welcome you to our call today.
Thank you very much. Thank you, Paige. Texas howdy to everyone. Thank you for joining in and being a part of this program. Over the weekend, I heard from my sister-in-law who lives in Minnesota, said there was 8 feet of snow. So I was remembering spring, trying to think about spring. So I wanted to show you a picture of spring in Texas. Two longhorn steers grazing in a field of bluebonnets behind a barbed wire fence. And I hope you all spring is coming to you all. It has come here where the bluebonnets are in bloom. I'm going to be talking about sleep today, and I thought I'd make it as easy as possible. I'm going to propose 5 questions and hopefully answer the questions, and so that it's possible to learn and share my interest in sleep. First question is, why talk about sleep? Why are we interested? Why do we spend any time today learning about sleep? And on this slide, I've shown several reasons why we should be concerned about sleep, especially for individuals with Rett syndrome. First of all, sleep problems are common and prevalent. In typically developing children, they affect and occur in 20 to 40%, but in children with neurodevelopmental disorders like Rett syndrome, it's anywhere from 40 to 100% of individuals will experience some sleep problem. These problems typically are chronic. They last more than a few days, few months, and more likely a few years for individuals with Rett syndrome and with other developmental disorders. Sleep problems can impact on mood, behavior, cognition. For example, children who do not achieve at least 10 hours of sleep before the age of 3.5 years later on have learning problems, attention problems, and developmental problems. Additionally, sleep problems can impact on the general health of an individual. There's clear evidence that sleep problems are a risk factor for the development of hypertension, cardiovascular disease. Having insufficient sleep can contribute to being overweight, being obese, and so it not only impacts on sleep problems impact on cognition, behavior, and your general health. Importantly, and as Paige has already said, sleep problems will impact on the family health and quality of life. One study showed that mothers of children with chronic sleep problems are at higher risk for developing depression and mood problems. But all of you who have children or children with Rett syndrome are aware of that you don't get a good night's sleep when your child is not sleeping well. And most importantly, sleep problems are treatable and possibly preventable. Second question is, in general, what does sleep look like? So I thought I would show you several slides that might help you understand sleep with primary emphasis on children, but also some information about adults. This is from the National Sleep Foundation. And what they did is a survey of a large group of families about their children, how they slept, and what is shown on the slide in the dark blue is the average required amount of sleep at any given age. Required sleep that is important for optimal function during the day, being alert during the day. So I actually wanted to demonstrate several things on this slide. First, the actual numbers. For example, in the newborn period, there's a requirement for, on the average, of 14 to 17 hours of sleep, whereas adults, we need 7 to 9 hours of sleep. In childhood, anywhere from 10 to 14 hours of sleep. The second point is, and you can see this nicely on the slide, there is a decreasing requirement for sleep. And I look at it in this way. You need a lot of sleep early on because it supports, enhances development. And so it's very important for learning for children who are developing rapidly in the first years of life. And the last point is there's quite a variation in the amount of sleep. So there's some people who need the large amount of sleep to function at their best, others who get by with a lesser amount. So your child, you are individuals and you have your own need, but these give you an idea of what that need might be. One last thing is these numbers are real. In epidemiological studies in adults, those adults who achieved 6 hours of sleep rather than 7 to 9 hours of sleep were at increased risk for mortality and morbidity. Likewise, achieving too much sleep, achieving 9, 10 hours of sleep, 10 hours of sleep or more, increased your risk for early death or morbidity from other causes. And this was controlling for other things like heart disease, obesity, and so forth. This is just to remind you of the number of hours and the points that I've already made in the previous slide. A lot of factors determine the amount of sleep and how you sleep. Genetic factors, ethnicity, cultural. There are differences in taking afternoon naps or co-sleeping with children. But I think important for Rett syndrome are two factors. First of all, the other medical issues in addition to their neurological problems. Issues that include GI problems, which can contribute to sleep problems, not getting a good night's sleep. Another important factor is medications. Many of these individuals with Rett syndrome are on many medications, and many of them have impact on sleep, either making you too sleepy, interfering with your ability to sleep at night, putting you at risk for developing sleep-disordered breathing. So another slide looking at what happens with sleep over childhood and teenage life. This slide, though, shows the proportion of REM sleep shown in the hatched lines and non-REM sleep shown in the gray solid coloring. The slide again emphasizes that actually we live in three different states. We're either awake, we're either in non-rapid eye movement sleep, sleep that would be a time when you don't dream and things are very stable, and we may be in rapid eye movement sleep, or dream sleep. The important aspect of this slide that I wanted to point out was early on you have a lot of REM sleep. Newborns have like 50% REM sleep, and that decreases until you become adults, decreases down to about 18 to 25%. What I would think is that REM sleep is very important for development, for learning. There's a lot of evidence that indicates that REM sleep supports many types of learning and is necessary for effective learning. One of the problems we see in Rett syndrome is many of the individuals have decreased amounts of REM sleep, and I think that may also contribute to their developmental problems and how well they do. This is another way of looking at sleep. This is called a Hypnobram, and what we do is plot out wakefulness, REM, and non-REM sleep over the time that an individual will be in bed and sleeping or up and awake. This is a newborn, and the characteristics of the newborn are these. You typically, if you're a newborn, you go from being awake to REM sleep to non-REM sleep, and you cycle usually throughout the 24-hour period. And those who have new children, babies, will be recently experienced in this type of pattern. This is in contrast to this hypnogram of an adolescent. So adolescents, by the time you're an adolescent, you've condensed your sleep during the nighttime. You alternate from wakefulness to non-REM sleep. So wakefulness down to non-REM sleep, and then cycle, getting periods of REM sleep later on in the night. And this is a typical pattern that not only children, teenagers, and adults, but adults also show. You will also see some times when they appear to arouse or awaken, and we all do that about 14 times a night, but most of us are able to put ourselves back to sleep and don't realize that we've actually been awake for brief periods of times. But some individuals, and especially those persons with Rett syndrome, may have difficulty with putting themselves back to sleep. So the real problem is not awakening, but learning how to put yourself back to sleep. And this is a significant problem in many children, and they have to learn new ways or better ways of putting themselves back to sleep. Again, this pattern, in contrast to newborn pattern, is consolidated during the night, alternates between wakefulness, then non-REM, rather than going into REM. The periods of REM sleep are consolidated and occur later in the night. And then finally, this is a recording from a sleep study. And this recording emphasizes one point is that a sleep study provides you with a lot of information, including brain activity in these channels, heart rate, oxygen levels, the waste gas carbon dioxide, breathing with airflow through the nose, and effort breathing with movement of the chest and abdomen. And we do this continuously for all the time that you're sleeping in the laboratory. So you have about 8 hours of data, continuous data. We put everything on film, so if there are unusual behaviors, we can go back and look at the actual recording and see if there were any changes in breathing and brain activity. This is your brain awake. It's characterized by an EEG pattern that's awake, muscle activity, and fairly irregular breathing pattern as far as the regularity of breathing. This is in contrast. This is your brain in non-rapid eye movement sleep. And the activity looks different. It's slower, but importantly, there are features of non-REM sleep called spindles that are the hallmarks of non-REM sleep. This is also non-REM sleep, but in this case, there's a lot of slow activity called delta activity. And this is slow wave sleep. It's important because this is the time when your growth hormone is released, and it's important to have this particular type of sleep in order to have those hormones being released and supporting function and repair of the body. These are in contrast to a period of rapid eye movement sleep. EEG activity sort of looks like awake, but there are these rapid eye movements which are here. They're less than a second in duration, and there's a lack of muscle activity except for some intermittent phasic or twitching of the muscles. You also notice that the breathing pattern is typically irregular during REM sleep. So that's your brain awake in non-REM sleep and in REM sleep. That's what a sleep study will show when recorded, whether you're typically developing individual or if you have Rett syndrome. Next question. What does sleep look like in Rett syndrome? And I thought of several ways of thinking about that. First of all, the importance of sleep problems and the frequency of their occurrence in Rett syndrome has been well recognized, and it forms a part of actually the supportive criteria for atypical Rett syndrome, as shown in this slide. An impaired sleep pattern is one of those criteria. Second, having reviewed a number of many sleep studies in individuals with Rett syndrome, children and adults, several things stand out. First of all, they have poorly defined or absent sleep characteristics. The spindles that I pointed out in the previous slide are frequently absent after the age of 2 years, so after the period of regression. They may reappear in adults, but it's a typical finding that individuals with Rett syndrome don't have typical sleep characteristics such as sleep spindles. This has led to a study that we're currently doing, trying to look and quantify the brain activity during sleep in patients with Rett syndrome to see if we can discover a biomarker that will be an early indicator of Rett syndrome and or give us evidence of children who have developmental problems. Additionally, individuals with Rett syndrome have reduced amounts of REM sleep. As you know, they frequently have seizures, and the epileptic activity, not necessarily the seizures, but the epileptic activity that are called spikes or sharp waves, actually increases in frequency and becomes very frequent during non-rapid eye movement sleep. They may experience periodic movements of the extremities of the legs. They may experience what we call sleep-disordered breathing, or what is called sleep apnea, either obstructive or central. Those are the typical characteristics of sleep as I've experienced it, my experience with studying sleep in individuals with Rett syndrome. We've also looked at sleep problems in individuals with Rett syndrome using validated questionnaires. What we wanted to know is, in comparison to their typically developing siblings, did they have more or less problems? What specific problems did children with Rett syndrome have. Second, we wanted to compare them to two other neurogenetic disorders, Angelman and Prader-Willi, to see if there were distinct features that characterize Rett syndrome. In other words, a sleep phenotype. In comparison to typically developing children, we found that individuals with Rett syndrome had more overall sleep problems. They endorsed more frequently having difficulty sleeping, experiencing disruptions of sleep, and other problems during sleep. The Rett individuals had more frequent problems with insomnia. That means difficulty going to sleep, staying asleep, early morning awakenings. They had more endorsement of daytime sleepiness than their typically developing siblings. And lastly, they endorsed and had more frequent sleep disordered breathing, whether it be obstructive sleep apnea or central sleep apnea. In comparison to the two other neurogenetic disorders, those individuals with Rett syndrome, their sleep problems were characterized by insomnia, daytime sleepiness, and sleep disordered breathing. The individuals with Angelman syndrome, children with Angelman syndrome, their sleep problems were characterized by insomnia rather than the other two. Those individuals with Prader-Willi were characterized by daytime sleepiness and sleep disordered breathing. However, when we compared the individuals with Rett syndrome to Angelman and Prader-Willi disorders, the individuals with Rett syndrome had more of insomnia, more daytime sleepiness, and disordered breathing. So sleep problems appear to be more frequent and more problematic in children who have Rett syndrome. In the current study, there are several questions that current natural history study, there are several questions concerning sleep problems. And at Baylor, we looked at our current enrollment for Rett syndrome, and we identified 60 individuals, some of them 10 years and younger, some of them 10 years and older, young adults. And one of the questions was just a general question: have you ever experienced impaired sleep or sleep problems? And those under 10, 60%, those over 10, 68%. But I think it's interesting for difficulty falling asleep, waking during the night, hard to wake up in the morning, symptoms, 1 of insomnia and 2 of daytime sleepiness. In the older individuals over 10 years, especially the adults, the percent endorsing these complaints significantly increased, and were more problems in the adults with Rett syndrome. Again, we compared these same questions, same findings in Rett syndrome to the other categories of patients in the natural history study. And in general, these problems were more frequent in the individuals with Rett syndrome than the other disorders, including the duplication syndrome, FOXG1, and CDKL5. And I also have had an opportunity to review overnight sleep studies in 36 individuals with Rett syndrome, and divided them in 2 groups, one a prepubertal group and the other over 16s and the pubertal or young adults. These are very selected and biased group because they were referred for sleep studies because they all snored and possibility of sleep disordered breathing. But I think the results are interesting from several aspects. In both groups, younger and older, their what's called OHI, which is the obstructive apnea index, the number of episodes per hour, was in the moderate range, not just mild, but in moderate range. And 30% of the younger ones and 50% of the older Rett individuals had severe obstructive sleep apnea. So this is a significant problem, and I think that reflects the overall experience in Rett syndrome. Oxygen desaturation below 90% is critical. It's one of the features that occurs with sleep disordered breathing, and 100% of those individuals over 16 in the young adult group experience periods of drops, significant drops in oxygen values. Interesting enough, the incidence of central sleep apnea, and this is the index, so for under 16 it's 2.8 per hour, over 16 3.2 episodes per hour, actually is in the minimal or mild range and much less significant than obstructive sleep apnea. So the main sleep disordered problem, breathing problem in Rett syndrome is obstructive sleep apnea and a much lesser degree of central sleep apnea. So that's objective evidence, even though it's in a biased group. It emphasizes the importance of considering the possibility of sleep disordered breathing, like obstructive sleep apnea, in all patients with Rett syndrome. Now I'd like to go to how we evaluate sleep, and we have several ways of doing it. The first thing is, I think it's important to be thinking about sleep and to evaluating it, even if it's a screening tool. And a screening tool like, it's a questionnaire called the BEARS, and each of the letters of BEARS represents a particular sleep problem, like bedtime problems, excessive daytime sleepiness, S for snoring. Something like that should be done by any physician taking care of an individual with Rett syndrome, whether it be a child or an adult. And this, if the answer is yes to any of this, then you need to go on to some further evaluation, and that could include further questions, trying to find out what's going on with this sleep, or even doing a sleep study. Other ways we have of looking at sleep is the sleep diary shown here, where a parent will record when their child is awake or asleep, when they wake up at night, what time they go to bed at night. It gives us a good idea, because we do the recording, the diary, we keep the diary usually for 2 weeks. It gives us a good idea over the 2-week period, how are people sleeping? Is it a very disrupted sleep? Are they getting enough sleep? And so forth. So this can be a powerful tool to understanding sleep in individuals with Rett syndrome. Another non-invasive test is what we call Actograph. This watch-like device, it's worn, can be worn on the wrist or can be worn on the ankle. And the paradigm is it records movement. And if you're moving, you're thought to be awake. If you're not moving, you're thought to be asleep. And you can actually wear it for days or even weeks, and it can give you an objective printout of what the sleep pattern is like. We use it frequently in patients where we want to know what is the sleep pattern. We want objective evidence of it. This is a setup for an overnight sleep study. As you can see, we record many things. We can do it in newborns. We can do it in children. We can do the sleep study in adolescents and teenagers. We can do it in adults. And in Rett syndrome, we've done studies in all ages in our sleep laboratory. And the recording, again, is brain activity, eye movements, muscle activity at the chin muscle in order to stage sleep, airflow through the nose and mouth, movement of the chest and abdomen to give you an idea of respiratory effort, recordings of oxygen levels, carbon dioxide levels, the waste gas, movements of the legs, again, continuously for the full duration of the study, typically 8 hours. It's put on video so we can go back and actually review it and see what the behaviors are in comparison to the actual recording of the parameters here from the sensors. So it gives us a lot of information. We can tell when you're dreaming, but we can't tell what you're dreaming. But it gives us information about the character, the quality, the quantity of sleep, and gives us a good idea of are there problems with sleep, and points us towards direction of potentially dealing and intervention. The reasons to do a sleep study include if you suspect sleep-disordered breathing or obstructive sleep apnea. So in patients who are snoring or have witnessed times when they don't breathe while they're asleep, they should be considered for a sleep study to see if they have significant breathing problems during sleep. It's done to what we call titrate CPAP. That's continuous positive airway pressure, a mask-like device that's worn over the nose, delivers pressure to keep the airway open, and is a treatment possibility for obstructive sleep apnea. If any individuals complains of daytime sleepiness, a sleep study may be indicated because things that go on at night, preventing getting good night's sleep, will result in daytime sleepiness. When there's suspected seizures, you have injurious type behaviors, unusual behaviors at night, a sleep study can be very helpful in characterizing and defining what those behaviors represent. Do they represent seizures or non-seizure behaviors, so-called Rett behaviors? And then if you suspect periodic limb movements or recurrent movements of extremities, the study will quantitate that and identify them too. So those are the reasons that we would consider doing a sleep study. But again, I want to emphasize this. Parents should feel empowered, and physicians taking care of individuals with Rett syndrome at any age should be empowered to raise questions about how they are sleeping. Are there potential sleep problems? Parents should let their physicians know, my kid's not sleeping, they're snoring, things like that. And then it can be determined, what do they need in the way of diagnostic tests? Do they need a sleep study? Do they need some intervention? And I think that's really the first step, is being aware of the problems, and two, asking about them or reporting them to your physician. So that's how we evaluate and the tools that we have available. And now the question comes up, well, how do we manage when we identify, how do we manage the sleep problem? The first thing is, the approach I take is, if we've identified a problem, I want to find out if there are any medical problems going on that might contribute to it. For example, GI problems, which occur frequently in individuals with Rett syndrome, often are worse at night. So GERD or acid reflux can occur at night, cause arousals, and things like CPAP or treatment of insomnia is not going to help in that case. So you have to be aware that individuals with Rett syndrome experience other medical problems that need to be evaluated and treated to help improve and make their sleep better quality. You need to manage daytime behaviors. If there are problems going on, anxiety issues, mood issues, they will impact on the quality of sleep and will need to be addressed in themselves. We need to look carefully at medications. Again, individuals with Rett syndrome are frequently taking medications. Some of them will cause sleepiness, some of them will cause difficulty sleeping and actually lead to insomnia. Information and needs to be provided to parents about how to help their children sleep better, what represents a sleep problem or doesn't represent a sleep problem. Again, I mentioned that we all arouse or awaken up to 14 times a night. So parents need to be aware of that a few arousals at night, if they're not prolonged and not necessitating parents going into the room, might be quite acceptable. You need to have reasonable goals that can be accomplished by families in view of their own situations, their living situations, what they can do, what's reasonable for them to do, and keep that in mind, that if you propose something that they can't do, you will compound the sleeping problems and make it more difficult for families. The second step is, if you've identified a sleep problem, treat it, and the most effective way that can be carried out. And so, again, I'm going back to what tools we have to treat, and that includes sleep hygiene. Those are measures to improve the quality of sleep, help you sleep better. We frequently use behavioral approaches. These approaches are suggested to be the first and primary approach to insomnia for typically developing children, and I think they can also be appropriate and be very helpful in children with developmental disorders like Rett syndrome. We will use medications, especially in the case of insomnia, and especially when it's very difficult to deal with the sleep problems and it's causing a significant impact on families. Mothers typically, and possibly fathers, are not getting the appropriate amount of sleep. I've had many mothers who said they've quit work because they're afraid to drive because they're so sleepy and they can't carry on their jobs. So in some cases it is necessary to help families, help their children sleep better, or to combine medication with a behavioral approach. CPAP, again, is a treatment that we will use for sleep disordered breathing. So I'd like to look at the treatments that are available based on the sleep problem that one has. For sleep disordered breathing, it can either be obstructive sleep apnea or central sleep apnea. And I'm going to show, again, a polygraph or a sleep study to just give the characteristics of central and obstructive sleep apnea. The first thing I wanted to do, this is a patient with Rett syndrome, adolescent, and this recording was done during the night. The patient is actually awake. The W's are for awake. And the pattern that you see is the typical breathing dysregulation that is seen during wakefulness in Rett syndrome. As soon as I find my arrow again. There. So there are periods when there's no airflow. There might be some chaotic effort here. Then there's intense breathing, more rapid breathing, then no breathing, and so forth. It's sort of periodic. This is the typical awake pattern. It can be associated with a drop in oxygen values, in this case down to 83%, with values above 90% considered to be normal. And this goes on for some period of time. This is actually 4 or 5 minute epoch of wakefulness. That's in contrast to sleep. During sleep, the breathing pattern should be regular without periods of disorganization that just showed you during wakefulness. However, people with Rett syndrome can experience what are called central sleep apnea. That's when there's no airflow and there's no effort. This is actually heart rate coming through here. So this is what a central episode looks like. Here's another central episode here. And they can be associated with drops in oxygen values, as this one is to 92%. But these are central apnea. And the experience I have is they are infrequent, but they do occur in Rett syndrome. That's in contrast to episodes where there's obstruction. There's no airflow, but there's continuing to be respiratory effort here, and there are 2 episodes here. There's another episode where there's decreased airflow. You'll hear this referred to as a hypopnea, but again, it's different than the obstructive apnea where there's no airflow. And again, these can be associated with drops in oxygen values, either mild or very significant with arousals of the patient. So they cause a disruption of the sleep pattern, chronic oxygen desaturation, problems that are contributing to poor health, development of cardiovascular problems, cognitive problems, behavior problems during the day because the patient achieves a poor quality of sleep, a disrupted sleep, and chronic drops in oxygen levels. So the approach to breathing problems, especially obstructive sleep apnea, include tonsillectomy and adenoidectomy. Frequently, the tonsils are enlarged in young children and contribute to blocking the airway. Typically, your airway collapses when you go to sleep, and with the tonsils being large, they will get in the way of that collapsed airway and cause airway obstruction. And often removing the tonsils and adenoids will relieve that obstruction and cure or significantly improve the problem. However, if you have Rett syndrome, you have often more than just big tonsils causing the problem. You have tone problems, either increased tone, spasticity, rigidity, or you have decreased tone, hypotonia. Plus, this is a neurological problem. Centers that are responsible for breathing, controlling the patency of the airway may also be affected. So tonsillectomy and adenoidectomy may not be enough in individuals with Rett syndrome. In adults, often the tonsils aren't enlarged, and so we have other means of trying to take care of sleep-disordered breathing. One of those is the use of continuous positive airway pressure. Another mode is bi-level positive airway pressure. And again, this is a mask that fits either over the nose or over the mouth, delivers pressure to essentially keep the airway open while you're sleeping so that you don't experience obstructive sleep apnea, and may also help with central sleep apnea, but to a lesser extent. It's primarily for obstructive sleep apnea. Other ways, simple ways, are often the problem is worse when you're on your back. When you're on your back, there's more likelihood of the airway collapsing. And so sleep position, having individuals stay on their side. And we actually have developed devices, or parents can do an easy thing. They can sew a tennis ball into the shirt that the child wears at night, so when they lay on the back, it's uncomfortable and they keep on their side. Weight management. Some individuals who are obese will have more significant obstructive sleep apnea. Again, like the tonsils, if you have you're obese, you have additional fat storage in the neck, and it will contribute to airway blockage obstruction. Sometimes we will use anti-inflammatory nasal sprays to relieve nasal inflammation. It will help improve and lessen the problem with airway obstruction. So those are the typical steps to dealing with obstructive sleep apnea. Sometimes it will also help with central sleep apnea. Typically, these are done before giving the patient additional oxygen, but if, despite these measures, despite using positive airway pressure, there's still significant oxygen drops, you might want to include the addition of supplemental oxygen at night. On the other hand, the daytime breathing problem, the awake breathing problem, disorganized breathing, I've known several patients who have been put on supplemental oxygen during wakefulness in an attempt to enhance the levels of oxygen, so when they do experience this awake pattern, the drops in oxygen values may be reduced. So I think that's one possible approach to awake breathing dysrhythmia, but not typically used for the sleep problem, where it's a matter of relieving airway obstruction. Second problem, common to individuals with Rett syndrome, and appears to be more common in adults with Rett syndrome. And insomnia is difficulty going to sleep, staying asleep, early morning awakenings, other awakenings throughout the night. So 3 measures that, okay. Excuse me. Okay. I will use sleep hygiene, and I'll go over what that means. Behavioral approaches, which essentially are directed towards extinguishing unwanted behaviors and rewarding positive behaviors, such as not disturbing your parents when you wake up at night, ability to go back to sleep. And then medications, and I'll discuss the use of medications also. Sleep hygiene. These are the measures you can do to help your child sleep better. They should have a time in bed that allows them to get the sleep that they need appropriate for age. So for middle childhood, that may be as much as 10 to 14 hours in bed. For older children, adolescents, it might be more like 9 or 10 hours. I suggest that before they are put to bed, that there's a 20 to 30 minute routine. That helps them identify, oh, I'm going to go to bed, I'm going to go to sleep. That routine might be reading, listening to music. I would suggest not watching the TV, which gives light exposure, which tends to keep you awake for a longer period of time. But music, book reading, talking to your daughter or son might be very appropriate. Also, taking a warm bath before you go to bed is actually helpful in a physiological way. One of the cues to your brain going to sleep is a drop in body temperature. So if you take a warm bath and get out of it, your body temperature drops, and that will be a cue to go to sleep. And often that actually helps you go to sleep in a more easy manner. Children especially, and adults also, should be put to bed awake rather than asleep. So they identify their bed as the place where they're going to go to sleep. The bedtime, nap time should be at regular hours that don't vary significantly from day or night to night. The bedroom, dark, but you could use a night light, like 40 watts dimly lit, if child sleeps better under that condition. Having a cool place rather than an overly warm place is conducive to sleep. Again, the drop in body temperature, cool, actually promotes sleep. It should be safe, especially if a child wanders or has sleepwalking, gets out of bed to do things. It should be a safe environment. I typically developing children suggest that they do not have telephones, computers, etc. in the room because they will use them. I realize in the case of Rett syndrome, there might be some devices like for music which will help individuals with Rett syndrome return to sleep, and I think that is appropriate. Again, you have to be reasonable when you're making these suggestions. Pre-bedtime meals, light snack is perfectly okay. If it's necessary to feed a child at night because they have a G-tube in and they're having issues with weight, that's to be approved and okay. Avoid caffeine, alcohol, and I mention alcohol not that I think a child or adolescent would be drinking, but because medications that you get over the counter or by prescription may have some alcohol content in them. You have to be careful of that. And avoid caffeine as it has a long duration of action and interfere with sleep at night. You would think that if you exercise a lot right before you go to bed, it would make you tired and go to bed easier. What we found is that exercising late in the night, right before bedtime, actually stimulates your brain and keeps you awake. But exercise earlier in the evening or in the afternoon promotes going to sleep at night and is to be advised, recommended. Light is our friend. Bright light in the morning, dim light in the evening promotes going to sleep at an earlier time. Vice versa, if you get bright light in the evening, it will keep you awake for a time. Bright light is not only the lights in the bedroom, ceiling lights turned on, but TV lights, things like that. You want to avoid that, especially late at night, because it will delay onset of sleep. So these are a few general things, sleep hygiene things that everyone can do, that families can do. Maybe they don't do all of them, but they do some of them to help their children, adolescents, even their adult daughters, to sleep better. Behavioral techniques primarily are those of extinction. You do things to extinguish unwanted behaviors and try to reward those behaviors you like. So if a child is waiting, crying until they get held, or they get a reward of TV on or some other reward, what you want to do is eliminate that reward. And again, extinction can be total extinction, where you totally avoid going in and checking on the child throughout the night. This will work in typically developing children and has a place in children with developmental disorders. More parent-friendly is gradual extinction, where if a child cries, you delay a small amount of time, go in and check, make sure they're okay, limit it to no more than a minute, just making sure they're okay, they don't need a diaper change, position change, something like that. And then the next time you delay it a little longer, and finally you get to a point where actually you delayed it to the point where a child goes back to sleep on their own. This takes a longer time to be effective than total extinction, but will work, especially in typically developing children, and has a place in children with developmental disorders like Rett syndrome. Relaxation therapy, it does help typically developing children, and I think really helps children with neurological or developmental problems. Relaxation therapy can include massage, weighted blankets. The blanket should be about 10% of weight. You don't want to get such a heavy blanket that it has potential for suffocation. They can be bought over the internet, and they cost anywhere from $40 to $200 or $300. Massage therapy might also include visits to the chiropractor, because doing their manipulations and things, they often are engaging in massage. But massage therapy, weighted blankets are good techniques to help children and adults be able to put themselves back to sleep or stay asleep. Medications. I'm frequently asked, can you give my kid a medication? And in the case of children with developmental problems with Rett syndrome, often it's not enough to do the behavioral approach. You have to combine it with medication. If you're doing sleep hygiene, you may have to combine it with medication to help them initiate and maintain sleep throughout the night. Unfortunately, in children, there are no approved medications. They have not been well studied, and frequently we use medications. For example, in the current enrollment in the natural history study, we looked at patients with Rett syndrome who are enrolled in the natural history study who endorse impaired sleep. 75% of them said at one time or another their child actually received a medication. For individuals over 10 years, it was 63%. That included teenagers and adults. And currently, of those patients that we have enrolled, those individuals are enrolled at Baylor, 40% of them are actually using a medication. The most frequently used medication turned out to be melatonin, but others used include clonidine, which is an antihypertensive, but the side effect is it makes you sleepy. Trazodone, an antidepressant, the side effect of which it makes you sleepy. Benadryl, an antihistamine, side effect it makes you sleepy, but it can have a paradoxical effect, making you activated and sleep poorly. Zolpidem, or Ambient, is an approved, in adults, approved hypnotic, which does help initiate and maintain sleep. Gabapentin is an anticonvulsant, side effect that makes you sleepy, and we found it very useful because its side effects are very infrequent. It can be given, a large dose can be given at night to help with sleep. Lunesta is an approved hypnotic that helps you initiate and maintain sleep. Valerium is sort of a natural product which I would not recommend, which you can buy over the counter, and I'm always concerned, does it really help you sleep? Does it have other potential effects? Many of these natural substances actually worsen seizures, and I would personally avoid them. Melatonin is a approved medication for sleep in adults and is a melatonin agonist and helps deliver melatonin to the brain, so it's helpful in the initiation of sleep. There are a number of approved medications for adults. There is a medication called Suvorexant. This is a new medication that helps or impacts on a neurotransmitter called orexin, which the lack of orexin leads to narcolepsy. And what this medication does is it's an antagonist to orexin and actually makes you sleepy, almost reproducing narcolepsy. But it's found to be very useful in adults for initiating and maintaining sleep. As I mentioned, Lumnestra and Ambient are approved medications for the initiation and maintaining sleep. A shorter acting, similar drug called Sonata can be given for initiation of sleep, but its duration of action is quite short. So that's the experience we have in our patients with medications who have Rett syndrome and enrolled in the natural history study. Medications that I have used include clonidine. It's frequently used in autism patients with psychiatric problems. The dose is a small dose. I think you have to carefully watch cardiovascular side effects, repeat the EKG, especially in Rett syndrome because of the incidence of long QT. Antiepileptics, I think gabapentin in children is a good choice. I typically start out with a nighttime dose of 10 to 20 per kilo. It's a single dose with increases as tolerated. Trazodone I've done a long time. It can affect QT interval. EKG needs to be monitored. Starting dose is a half a tablet or 25 milligrams up to 50 milligrams. Melatonin can be effective, especially in developmental disorders in children. It is not approved for adults, recommended as a hypnotic, but in children, I think it can be useful. You can use melatonin in two ways. A very low dose, like 0.3 milligrams, it comes in a liquid form to give that dose, can be used about 4 to 5 hours before desired bedtime in order to help you go to sleep at that time. It advances the sleep phase, you're going to sleep. In a higher dose, 2.5 to 10 milligrams, it can be used as a hypnotic. The problem I find is initially it can be very useful, used as a hypnotic. Then after a month or two, it becomes less useful and you have to look to other things. But it might give you the opportunity to help with sleep and initiate sleep hygiene and behavior techniques during that month or two. I've not found the CR, the long-acting, to be all that more helpful than the short-acting melatonin. And again, melatonin is primarily helpful in initiation of sleep, not maintenance of sleep. Risperidone is a medication I would use for behaviors, self-abusive behaviors, but we found in children with autism and Rett syndrome, a small dose at night before sleep in children who have behavioral problems, it will help them, possibly eliminating those behavioral problems, help them go to sleep, and combined with something like melatonin or with gabapentin might be beneficial to improving sleep at night. The third problem that we found to be common in individuals with Rett syndrome is awake-sleep scheduling. These are especially adult patients who tend to be sleepy during the day and don't sleep at night, who are reported to have these long periods, like weeks of sleeping a lot and then weeks of not sleeping at all. And so I think their problem is really a wake-sleeping scheduling problem, where they have delayed sleep, awakenings at night, and especially daytime sleepiness. And I think the same approach that we use for insomnia, sleep hygiene, the use of melatonin, especially as a phase advancing 4 to 5 hours before desired bedtime, might be helpful. A newer medication that we're looking at is pitolisant. This is a very unique medicine that affects the histamine. It enhances the availability of histamine, and so it's a wake-promoting agent. And it's used in Europe to treat narcolepsy, has been found to be effective for narcolepsy and cataplexy, but I'm wondering if it might not be effective for other individuals, such as those with Rett syndrome who experience daytime sleepiness. It's given in the morning. It does promote wakefulness, and so if you give it at night or in the evening, it will keep you awake and worsen your insomnia. But this is something we're looking at. We're actually doing a study, and hopefully this medication might be approved in this country and could be available for use in that situation. And a bonus question, what have we learned? And this is sort of a summary statement. Again, sleep problems occur frequently, seem to be chronic in individuals with Rett syndrome. I think there is a sleep phenotype. Characteristic sleep problems include insomnia, sleep-wake dysregulation and daytime sleepiness, and sleep-disordered breathing. The importance of identifying them, of parents reporting them, of doctors asking the questions, and then evaluating and managing the problems in order to improve and long-term improvement and prevention. It's important to the health and best functioning of all individuals, especially individuals with Rett syndrome. And thank you all for listening, and a good night. Paige, I'm ready for questions.
Great. Thank you, Dr. Glaze. Those were excellent slides, a lot of great data, a lot of great observations, and a lot of great recommendations. We appreciate that. We have quite a few questions that have come into the queue. A lot of them you did answer in your slides, so if you want to readdress them or remind everyone that they will have access to this recording and they can fast forward and rewind once they get the recording link to hear your answer again, that would be fine in the interest of time.
So let's do that in the interest of time. I know there were a lot of questions about what can I do for my child who can't go to sleep, doesn't stay asleep, and so forth. So I think, again, they've been addressed in the talk, and the information will be available.
Great. Okay, so I will go through the queue, and we'll take about 30 minutes here. We should be able to get to everything that's been submitted in the queue. If you have a question that Dr. Glaze didn't answer, or maybe a question that was triggered by a data point that he presented, go ahead and type it in here, and I can then capture everything that is of interest. And of course, you can always email us or call us at any point after today's session. Okay, so one of the early questions is around sleep hygiene and some of the things that you recommended. Thank you for that extensive explanation of what sleep hygiene is. One of our attendees has a question about use of other interventions like a chiropractor, essential oils, acupressure. Are you familiar with any of these techniques, and do you have some thoughts?
So I am familiar and have many patients who do those things, who those things are done for. I think, first of all, essential oils probably are in the lungs of relaxation therapies, massage therapy. They sound fine to me. They might be used in a different way than just massage therapy. The chiropractor, again, I'm a little concerned about the chiropractor and what they're doing, but I think some things that are doing, again, are relaxing measures and overall relaxing. I don't have any direct experience, or I don't usually recommend them, but in most cases, I think it's fine to pursue that, but just be careful for safety's sakes about manipulations of back and neck and things like that. Next question. Yeah, thank you. And I agree. I think as our girls and women can have
hypertonia and different issues with dystonia. They may be uncomfortable. So talking this through with a physical therapist might be a good start.
That sounds good.
Okay, so next question is, quite a few families were asking about the sleep questionnaire and the sleep diary and feel that that would be useful for them. Could you get those to me, Dr. Glaze, so that I could post them to the website and make them available to our attendees?
So I don't need to send them to you. They're online now. The questionnaire, that's a very simple questionnaire. It was designed for use by pediatricians in their busy office. It's called the BEARS, B-E-A-R-S. I think you can actually find it online if you just put in BEARS and sleep, but I will send you a copy of it. The sleep diary, there are lots of sleep diaries, and any one of them can be used. They are online as a resource, and I can send you a copy of the one we use, but most all sleep centers have a sleep diary. There are examples of them online. I'm glad to send them to you, and you can share them.
Great. Thank you. I can look up the BEARS questionnaire, and I can put the link up. If you have a diary that you've modified for some of the typical issues in Rett syndrome, that would be fantastic. Or whatever you find most useful in your sleep lab in the sleep center. I appreciate it.
And again, the BEARS, the BEARS are a beginning questionnaire way of at least identifying that there is a problem. They're not the final answer. You still have to do more evaluation than that. But they're a quick way of doing it so parents can say, oh, my child has these problems. I need to bring it up to my pediatrician, or pediatricians in their busy office. Their nurses or helpers can actually do the BEARS and identify the problems, and then they can go on to further address the issues. Okay.
Okay, thanks. Next question. Commonly we hear this in sleep studies as well as epilepsy, seizure, EEG studies. My daughter seems to have a lot of sleep issues, but she sleeps like a charm when we go in for our sleep study. So there's two-pronged questions. One is, during the sleep studies, they do see abnormal EEG that they don't suspect is epilepsy, but we're not capturing the sleep study or sleep issues. Second question related to that is there any assessments or tracking devices that can capture sleep at home if we're not able to capture it in the clinic?
So I'm going to talk about the second question first, okay? So again, actigraphy is a device that sleep physicians use to capture sleep at home. You wear this wrist-like device, and you wear it for a couple of weeks. It records, and you wear it continuously except when you take a bath or a shower. And it records movement, and it has a computer device that can download to the information and then develop a pattern of sleep, what sleep has been like, and gives you a fairly objective idea of how individuals are sleeping, and if there is a problem or there's not a problem. Are they sleeping during the day? Are they not sleeping at night? Interestingly enough, and you're all more familiar than I, because I'm so old that I'm beyond this electronic age sort of, but you can go to your local Target or Walgreens or Macy's or whatever and buy similar devices. You know, watches now can record sleep, and the way they record it is activity, like the Actograph. So, you know, you can do it on your own and acquire one of these devices. Usually children will wear them. They're not terribly invasive. And again, you can actually put them on their ankles. They won't keep them on their wrists. So that's a device that often we'll use that provides useful information. I would prefer to use one of the devices that I'm familiar with and that has been studied and approved for use with sleep. Going back to the first question, and I'm very familiar with what happens when you go in. Your daughter is having seizures every day, but when you get into the atmosphere of the EMU, the epilepsy monitoring unit, or the sleep lab, nothing happens. And often we will keep those children or those individuals for many days, even a week. Otherwise, we can actually do home ambulatory EEG monitoring if we don't capture something, and the home ambulatory monitoring can be useful in many cases where we're not able to capture the specific behaviors. We can send the child or adult home with this attached with recording of brain activity too, and then wearing it for several days, and with the hopes that we will capture the behaviors out of the atmosphere of the epilepsy monitoring unit. In respect to the sleep laboratory, again, insomnia is not an indication for a sleep study. Careful history, intervention for sleep problems. However, you suspect that things might be contributing to the sleep problem, such as breathing problems, then a sleep study is indicated. And if you're having breathing problems during sleep, they will be present every night, and the one night recording is, in the vast majority of cases, sufficient to evaluate breathing during sleep. The sleep study also will evaluate the EEG. If there's a history of seizures, they can add more electrodes over the brain or the scalp and to record abnormal brain activity. That might not be seizures, but it would be the abnormal brain activity, and will give you at least hints or an indication that the patient might be at risk for seizures. But I know this is a problem, and again, in the epilepsy monitoring unit, often we'll keep patients for many days, or we'll go ahead and reduce their anti-epileptic drugs, even though that may allow them to have a seizure, because it's so important for them to have their behaviors. They may have behaviors that are non-epileptic behaviors, often referred to as Rett behaviors. These can be twitching, staring, unusual movements with or without breathing irregularities while awake. But we can record those, and importantly, we can record if they are or aren't seizures. If they're not seizures, we don't have to commit the individual to an anti-epileptic drug. If they are seizures, it helps us make the right decision. Okay. I think that might answer that question, Paige.
Okay, I think so. And if someone has a follow-on question to that explanation, please go ahead and type it in now. Okay. Another question is about managing sleep problems. In the study in the chart that you showed earlier, when you looked at some of the patients with Rett syndrome that you did sleep studies on at the clinic, were those girls and women across a spectrum, a typical spectrum of Rett syndrome, or were they more impaired? You said the data was a bit skewed because they'd been referred for sleep issues, but did they represent a good sampling of people with Rett syndrome, ambulatory, non-ambulatory, et cetera?
Yeah, they actually do represent a good sample. Some of them were ambulatory, some not. Some with severe motor problems, and others with less severe problems. So I think it represents a good sample. The indication that Rett syndrome has a high incidence of moderate to severe obstructive sleep apnea is probably correct. I think we have to be aware of that, and in all patients be screening them for sleep disordered breathing. Can I go back again to the previous question, that often when Rett individuals or individuals with Rett syndrome, or even typically developed individuals with insomnia come in for a sleep study, they don't have their insomnia. And I think it's because, in a way, they're in an artificial setting which reproduces what we try to do in sleep hygiene. They're confined to bed. They're not allowed to get out of bed. And I think that actually is the reason why, if they have insomnia, it isn't often they sleep better in the sleep laboratory than they ever do at home. And it's true for Rett syndrome as well as just children and adults with insomnia. Okay, that's the previous. The current question is, again, the sleep studies we reviewed, I think, while they are patients who came to the sleep lab because they were snorers and possibly had sleep disordered breathing, I think they are a fair representative group of Rett syndrome. It's the full spectrum of Rett syndrome, not just the most severe. Okay, does that answer that question?
I believe so, and if it didn't, please go ahead and type a follow-up question in the queue, and we'll get to it if we have time today. Thank you. Following up to your comment that sometimes the kids sleep better when they're in the sleep center as opposed to at home, goes to another question about positioning and the use of a hospital bed in the home. Can you comment on that and your experience with families who have been able to secure a hospital bed? Has that been really helpful? And if so, do you have some suggestions about getting one approved through insurance in the U.S.?
I've had some families obtain that. They feel that their children do sleep better. I think it's a matter of perhaps being able to position them, raise the head of the bed up, which allows them to sleep better. And as far as advice, I think what I would say is I personally will try very hard to support the acquisition of that type of bed to improve sleep and well-being of the child. I don't think we're always successful, but we try our best to be creative about the letters we write and what we do in those situations.
Okay, and a follow-on question is for positioning, raising head and legs. Circulation is good, but also what about beds that are more enclosed, like a sleep-safe bed, in order to keep the girls safe who move around a little bit, but the family wants to be able to let her be safely in peace to get herself back to sleep?
Yeah, no.
Is that considered a medical? Is that considered a medical issue?
That may be a medical issue. Again, first of all, it's sort of like weighted blankets, almost, but in another way, confined, so you know they're not getting out of bed, they're not falling out of bed, and the families perhaps can get a better sleep. I think there's the issue about safety of those beds, and one type of bed is no longer in use because of the safety issues. So I think you have to be very critical, no matter what you're doing for your child, that it's safe, that it's doing what you hope it's going to do. If it is safe, it does seem to help. Again, personally, I'm willing to make the effort to see what we can do and frame it in terms of it is a medical issue, from the standpoint of improving not only sleep but the health of the child and the well-being of the family.
Okay, great. Thank you, Dr. Glaze. We have a series of questions that kind of follow thematically. Since we're getting to the close of our time, I want to pull them together, but I will also export them and get them all to you, Dr. Glaze, for consideration for writing up a QA. But I think that there are some ones that are really important that I hear often from families. And the first one is about tremoring when coming awake. If there's any intervention, if you have any thoughts on that. Also, children who have a seizure commonly like an hour after going to bed or an hour before normal wake time, infrequently, but are these epilepsy issues? Are these sleep issues? Where do you start? with the tremoring or with the infrequent but single seizure that's just right at kind of maybe going into REM. Can you talk about that a little bit?
The first question, we see many children who experience tremor or have difficulties with balance upon awakening. And I think it's a matter of, I sort of think in terms they need to be jump-started before they can get going. That if you have a neurological disorder, it takes your brain a bit of time to get focused, to get going in a proper way, to get everything in balance. And my experience has been, first of all, these are not seizures. Reassure parents that, as best I know, they're not harmful to their child. And my experience has been, in 100% of cases, after a short period of time, the child comes back to baseline, is no longer having the tremulous-like behavior, no longer having the difficulties with ambulation. But it takes a time for the brain, having been asleep, to get fully awake and back to their baseline. I think that can be seen in other neurological disorders too, that neurological disorder that affects the brain puts you at risk for that type of behavior where you're transitioning from sleep, especially if it's been very abrupt. As to the second question, clearly seizures do happen in relationship to sleep, and sleep can be a precipitating factor. Clearly, going to sleep increases in many individuals the occurrence of epileptiform abnormalities, spikes, in sharp ways, which might not be seen awake, but are seen asleep and are very abundant. Typically, that occurs during non-REM sleep and much less frequent during REM sleep. Most seizures are more likely in relationship to non-REM sleep. I think medications, the first thing is you have to make sure there are seizures and not some other Rett behavior or motor behavior that is non-epileptic. And so in those cases, sleep study, prolonged EEG monitoring with video might be helpful. Things like sleep apnea might precipitate those types of events, either seizure or non-seizure, especially if they're associated with drops in oxygen. So the sleep study might help you identify, is something precipitating it, causing it to happen? Is there something we can do about that precipitating factor? So something more than just giving an anti-epileptic drug. So I think this is not infrequent, these behaviors you're describing. It's a matter of being sure what they represent, two, dealing with them appropriately, including not only if they're seizures, but also are there precipitating factors, and three, reassurance if they're not seizures, that they may be benign and will resolve in a short period of time.
Okay, great, thank you. We hear that a lot. I appreciate you addressing that. We also have a lot of questions about the use of CBD, cannabinoid, and if you have heard any comments or had any experience with CBD oils improving sleep or affecting sleep. And I would say that probably leads to our other question about other clinical trials that are starting or will be starting or are underway with Rett syndrome that are looking at sleep. And do you have any thoughts on those?
So I'm going to comment on both of them. First of all, I have very limited experience, and the only experience I have is what parents tell me that they've acquired some similar drug or cannabis type drug, and at least that type of experience. I'm not going to tell them myself. Okay, I have some knowledge though that this drug might be helpful with sleep and might either as an anti-anxiety type drug or actually direct effect on sleep. However, my experience is limited. I think in general the experience is limited, especially in regards to Rett syndrome. Now the commercial part. So in May, I'm supposed to get together with GW, a company that makes the Epidiolex, and discuss a protocol for Rett syndrome. And this is now widely known that that company is interested in trial of Epidiolex for Rett syndrome. I think that is really important because it's the best way to answer the questions that are being raised. It's the safest way because I'm concerned that products might be obtained which are a mixture of a variety of cannabinoid chemicals which might have potentially serious and significant side effects. So I will have to say studies are in the future, soon in the future. I think that's the way that needs to be going. GW has planned a study, and I think that's the way I would like to go and try to get the answers to all of these questions. The medicine Epidiolex is approved for certain types of seizures, and again, it's not the one and all answer for epilepsy, and still it's unknown if it would be the one answer for sleep or anxiety issues in Rett syndrome. Paige, does that answer the question?
Thank you. We appreciate your information on that. There was quite a few questions, and we do look forward to hearing more from GW about their study and the outcomes they'll be looking at. Okay, let me give you 2 more questions. We'll wrap up for the day, and then we'll take the others that are offline that are more very specific to a specific child or asking for device names or links. I think those will be best captured in a follow-up QA. So for the child who's a bit more low tone or is very low tone, has reflux, feeding tube, parents, the child has a lot of sleep issues, but they're very reluctant to try drugs that might make her more low tone or more sleepy. For kids that fall in this category, what are your recommendations? Is it oxygen? Or I'll leave it there. Let you answer.
Well, I really appreciate those parents who are leery of using medications, especially like benzodiazepines or other medications that will relax their children and in the face of hypotonia might make things worse and breathing worse during sleep. My approach would be, let's find out, are they having breathing issues during sleep? If they're having those breathing issues, then appropriate management, which might include positive airway pressure, use of that, or the use of oxygen. The oxygen won't help if they're having airway obstruction. It will help hopefully maintain oxygen values in a more normal and acceptable range. Then, if they indeed have sleep disordered breathing, indeed if they're treated with positive airway pressure, other means to help them breathe, then medications such as that are hypnotics or sedative type medications can be used more safely. So I think the approach is identifying the extent of the problem, what's going on, especially from the standpoint, is there sleep disordered breathing, addressing that issue, and then are there still sleep problems? Many individuals will still have difficulty sleeping, where medications might be helpful in that circumstance where you are taking care and dealing with the breathing issues in an appropriate way.
Thank you. Thank you, Dr. Glaze. Okay, and we have, let's finish up on this. I think this gets to the part of your talk of getting everyone to have decent sleep in the home. So we have some families that have done a good job getting her to sleep, sleeping through the night, but she just chronically wakes up early in the morning. They've tried different medications, but she just insists on waking up earlier than everybody else in the house. What are your thoughts?
So, that is a very difficult problem and problem we deal with. So the first question is, what does she do when she wakes up? You know, is she able to get out of bed? Is there a safety issue? Do things like music, use of electronic device in this particular case, does that help relax her? And so that she's not disturbing other individuals in the household. If she's not able to get out of bed, but able to be quiet in bed, maintaining her bed until the rest of the household is ready to get up, I've seen occur on many occasions. Again, it has to be done in the context of what the child is doing, what she is doing when she wakes up. Are they already giving medications for her to sleep at night? Would other medications which have a longer duration of action, which work not only for initiation of sleep, but maintenance of sleep? Is it possible that you might want to give a short-acting medicine a second time during the night to help with sleep for this issue? So I think careful exploration of the problem might identify some techniques or some approaches that might be used. And most importantly, how significant is the problem? Is the problem one of family sleeping and concerned that she's awake? Is she quiet while she's awake? Then you can deal with that, and hopefully the family can sleep while she's quietly awake in her own room in a safe environment. But I think there are some possibilities, things that could be done to help with sleep in this case.
Okay. Thank you very much, Dr. Glaze. We've reached the end of our time together, but we will export all of the questions asked today, and I will consult with Dr. Glaze and get a QA document developed and posted to the website. Give us a little bit of time, but we appreciate all of the questions. They're all very good, and we know that this is a very big quality of life issue as well as a medical issue for our children. So Dr. Glaze, we really appreciate that you took the time out of your busy clinic and your research activities to share your learnings and suggestions with all of our families today.
Thank you all. I really appreciate it. Paige, thank you. You've been really helpful in getting this set up and getting it done.
Well, we really appreciate the opportunity to do this, and so glad that we have technology to allow us to do these webcasts. So I want to thank you again, and I'm going to take back the screen here to remind some folks of our future education opportunities. This is just one of many issues that we are grappling with with Rett syndrome. And let's see, if we go to my screen here, I want to mention to all of our attendees, families, clinicians, researchers, industry, everyone who joined us today, that we hope you found value in today's specific session, and that the knowledge you heard and learned will help you in ways within your family, within your research, within your treatment of those with Rett syndrome. It's complex. We're making exceptional progress. My request to all, especially to families, is that you try to best to understand the recommendations put forth by Dr. Glaze. Try them. Keep faith that what your child experiences today may not be a problem for her tomorrow. That's a mental health thought that I think will keep us all well on our journey with Rett syndrome and as research progresses. Also, we want you to sleep well, knowing that we are pushing for research into better treatments, better control of issues like sleep in Rett syndrome. And I do want to ask all families that we need your involvement greatly to make change in this area. So when you see us ask for your support in completing a questionnaire or a survey, enrolling in the natural history study, considering tissue or organ donation or contribution to a biobank when those times come up, or to consider participating in a clinical trial, that you do so. We can't make progress without your involvement. And if it seems that it's difficult or out of reach for you to participate in any of the many research studies that are underway, please contact us and we'll help you talk through the decision tree for you and your family. We're at a time when true research participation is not only a reality, it's as critical as fundraising to make progress. And we want to make a special thanks to all that have contributed and participated and have been trailblazers to get us where we are today. We believe that information on our rare disorder should be free to all those who avail themselves of it, and we thank our supporters for their shared belief. That allows us, these webinars allow us to direct even more dollars towards funding comprehensive research, and but enabling us to helping you stay connected to best practices in the here and now. We are involved with some education days across the country this year that will give you an opportunity to meet face-to-face with Rett experts and to meet other families in your area. These are some dates that either a local Rett Syndrome Association or a Rett Center of Excellence is hosting their own event, say April 12th, St. Louis, April 27th at Gillette Children's Hospital in Minneapolis. Or if you are looking towards dates in May, June, July, Pennsylvania, Massachusetts, California, these are education days that RettSyndrome.org is partnering with the local centers of excellence to host an education day. So if you're looking for more face-to-face opportunities, there's quite a few happening this year in cities across the country. We also have our monthly RettEd webcasts, and we hope that you'll join us next month on April 9th at 1 p.m. Eastern on the topic of IEP strategies for successful inclusion. This RettEd presentation will be with an expert panel of speakers that will include parents and paraprofessionals and special educators who have tackled this issue in their own lives. And I think this will be a really valuable topic as well. So thank you everybody for joining us today. We will again take all of the questions. We will evaluate which ones need some further consideration, explanation, offer links and PDFs to some of the things that Dr. Glaze shared with us today, and we'll get that out to you. You'll also receive an email within a day or two of a link to the recording of today's presentation. Please feel free to share that with your care teams, within your families. Go back, rewind, fast forward. There's a lot of good information, and we really thank you, Dr. Glaze, for being with us. That now concludes our webinar for today, and we look forward to talking to you next month. Thank you. Bye-bye.